This community forum has been organized with the sponsorship of PFLAG Bakersfield, Bakersfield AIDS Project, Bakersfield LGBTQ, and the Gay and Lesbian Center of Bakersfield. With these organizations working in concert with the health department and other governmental agencies, we're going to be able to reduce new HIV infections in our community. That's the most important thing, is to work together. So, I'd like to thank Bakersfield LGBTQ for getting this venue, the comfortable seating and everything. So thanks to Bakersfield LGBTQ for that. I read 3 blogs a day religiously, and about a year and a half ago I kept reading about PrEP and Truvada and HIV, and I just scrolled through and I didn't pay attention. I thought, yeah, we've been hearing that for 30 years. And for some reason I clicked on the headline and I read it and I couldn't believe what I was reading. Why aren't we dancing in the streets? You know, if this was in the 1980s or 90s, we would have been dancing. This was the answer to our prayers. But for some reason, whatever reason, it didn't make the news. People still don't know about it, and I can't figure it out. Let me put it in perspective. About 14, 15 years ago, a medication was developed to help men with erectile dysfunction. And it made headlines all over. It made all the national news. It made all the local news. And for 14 years, they haven't shut up about it. And as far as I know, nobody's ever died from not getting an erection. And you know, here we are with a virus that's killed 25 to 30 million people worldwide. 50,000 people for the last 10 years are infected every year. 50,000, 47, 50,000, right around. 100 to 150 people a year are new HIV diagnosis right here in Kern County. So I don't get it. I don't understand it. Here we have a preventive medication that prevents a virus that one of the most deadly viruses that mankind has ever encountered, and nobody's talking about it. I don't get it. And that's why I wanted to organize this community forum.
When Robert first started talking to me about PrEP, I was kind of like not really sure about what he was discussing, because I really hadn't heard anything in any other ways, not through Facebook, not on Google, not in advisory board minutes, not in the newspaper, and so I wasn't really sure about what he was talking about. So, but he asked me a couple of times, and so then I started looking at it, and I called the health department to ask, and then they asked, and so anyway, long story short, after about 4 to 6 months, here we are, and I'm very thankful for it. We are very blessed here in Kern County to have this evening, to have this dialogue, because I think it was just maybe a couple of weeks ago where in San Francisco they were sharing some information with the mayor was there discussing it, and then I've also seen on Cleve Jones' feed. So this is very new. It's new to us. It may be 2 to 4 years ago for other areas, but as far as getting the word out, it's still very, very new. And so I'm really thankful to be able to be part of this evening and to have Bakersfield AIDS Project helping to sponsor, and then of course standing alongside of Bakersfield LGBTQ and PFLAG is amazing, as well as the Gay and Lesbian Center. So as we are here tonight to learn more, and I look out there, I see so many of you that are like me 20 years ago when we first started talking about AIDS. And it was so hard because we knew there was not a cure. And it was just the human element of HIV. And that's what I always look at. Not the numbers, not the statistics, but the people, the humanity behind the statistics. And so for me, today is about hope. And as we've been seeing the drugs for treatment for our persons who are positive and they're living longer, that's just absolutely amazing. And it's also bittersweet when I think about the number of people that didn't have the opportunity to have those medications. But isn't it exciting to be gathered here tonight to be talking about prevention for HIV negative people, right? That deserves a round of applause. That deserves a round of applause. So I look forward to hearing more information, and I look forward to hearing the stories and listening to the doctor, and also listening to Mr. Leather, and listening to you, because collectively, this is how we deal with issues such as these. And so thank you, and I also want to recognize Claudia here also from the health department. Will you please stand? And I just want to, say how thankful we are to have you alongside of us. So let's not forget about the people. Thank you for being here, and let's find out what we need to know and get the word out.
On behalf of Bakersfield LGBTQ, first of all, I want to say how pleased I am to see so many people here tonight. You're going to be the acolytes for this movement to bring change to our world. If you're of a certain age, you remember when AIDS first came, and you remember the stigma, and they called it a gay disease, and then they called it the gay and drug addict disease. So it didn't matter that they weren't really reaching out to people, that our government turned its back on people who were suffering. The LGBT community is mobilized, and thank God for that. But the rest of the world seemed to think that, in the words of those unenlightened, that this was somehow deserved, that we asked for this. We didn't. And there's a certain amount of anger that's been seething underneath our skin ever since. Though things have changed some, there's still a lot of people out there in the world who stigmatize AIDS, stereotype AIDS, and they turn it into something that we don't have to care about that, because it's just the gays, and it's just in Africa, and we don't care about those people. And if you don't mind my saying, that pisses me off. What shocks me is how we could have a drug that prevents AIDS, and that is not in big neon signs all over America. That is not headline news in the New York Times. That we're not hearing about this from every quarter, that you're not sick of hearing about it on Facebook from somebody besides Robert. This should be something that everyone is talking about, everyone is passing the word, that when you go to work tomorrow, you say to the people at the water cooler, hey, have you heard about this? Because we know that AIDS is not a gay disease, or it's just in Africa. It affects everyone equally. If a person is sexually active, they're at risk. So we need to stop this idea that the only people we need to worry about are our gay brothers. We need to worry about everyone. And secondly, we have to push for people to continue to speak out, for our elected officials to care about this issue, enough to fund it, enough to make it possible for people to be able to afford to get this drug without necessarily having to spend thousands of dollars out of their own pocket. Yesterday, Channel 17 ran a thing saying that Kern County was 11th in the state in HIV. And I have to say, from the coverage that I saw, I was a little disappointed that out of all the things that were said this week about HIV, that is what they chose to put in their headline. And in the coverage that I saw, very little about what this meeting tonight is all about. So we will also be chasing after our press representatives. See all the incredible TV cameras in the back? The radio reporters?
LA Times is here.
LA Times, where are you? LA Times? Thank you. Thank you. They have to come from LA. So we have to push. I love LA, don't get me wrong. Our local media should be here. And they should be the ones who go back to their news stations tonight, and this is the top story. We're going to save not hundreds of lives, not thousands of lives, but millions of people. But if it depends on, gee, you knew somebody who heard about it from somebody, it's going to take forever. And in the meantime, people are still getting infected. And people are hearing myths, even if they know something about this new drug. They're hearing all kinds of myths. So thank you for coming out tonight, to be educated, to learn about this new opportunity we have to change the world. But we have to become preachers. People have to get sick of hearing about it from us. Get the t-shirt, get the tattoo, whatever you have to do. Spread the word. Because if we don't, who is? Except the LA Times. Thank you.
The health department is here, and that's great. Thank you, Denise Smith. But they can think this is the best thing in the world, but they can't do anything about it unless they get the funding. And they have to go to their bosses, and their bosses are elected by us. So the next time you see a politician show up on your doorstep asking for your vote, ask them what they're going to do to create access to their clientele for PrEP. And then if they look at you like you're speaking Martian, then educate them about PrEP.
So what I think is important to understand, I don't know if anybody's seen the headlines, we actually were able to trace back where HIV originally came from, and it actually comes from the simian immunodeficiency virus, which IV stands for immunodeficiency virus. So that's sort of the biological trace back. There is also, I don't know, a lot of people don't know that there's different types of HIV. So there's HIV-1, which is very, very common, and that's basically what we're talking about today and what we're preventing. Then there's HIV-2, which is very, very rare, especially within the United States. I think there's only 162 cases in total out of 320 million people, so just to know how rare it is. And primarily it's found in Western Africa. So it's also a lot harder to contract than HIV-1. It's a lot harder for it to stay alive within the body. So there's a lot we know about it. So let's keep focusing on HIV-1 because that's the main focus. Then also within HIV-1, there's numerous subtypes, and you know, there's 9 major subtypes. And there's one drug that sort of handles all of them pretty damn well, and that's Truvada, which is what we're going to talk about today. The first case of HIV was traced back to 1959. That's the first person that was sort of that was immediately found to have been somebody that had HIV. And then in 1981, Nick Rock was the first person to die of AIDS in New York City. And that's sort of when the gay community came together and we were like, wait a minute, what's going on? And I think what happened 35 years ago is we all sort of came together and we sat together and we said, there's something going through our community and we need to talk about it, and nobody wants to talk about it. Reagan went on TV and said, abstinence, you guys don't reproduce, just don't fuck. Sorry. F***. So, and then, you know, we fought on, and we got really loud, and we got aggressive because we were on the fence. We wanted to defend ourselves, we wanted to defend our community. And I think that's because the gay community and the LGBTQ community in general was very, very active during that period. I think what happened is that that's why HIV got so heavily associated with us too, because we were the loud voices talking about it. And I'm so grateful to see young people here, and to see straight people here, and like literally everybody, because as said before, this concerns everybody. So let's not be really boring, so I'm gonna do this really fast. There's 1.2 million people within the United States that live with HIV. As we already heard, there's 50,000 new infections of HIV every year in the United States, and there's 180,000 people in the United States that do not even know that they have HIV. And that is because testing is not one of the most common things. If everybody wants to close their eyes and raise their hands, who gets tested every 3 months? Good. Who's from now on going to get tested every 3 months? Okay, that's 2 people more. More hands! Who in this room has been sexually active in the last 6 months? Everybody who has their hands up? You know what you do every 3 months from now on? And we'll talk about this because there's a lot of fear and stuff like this going wrong with it. So anyway, so within the state of California, there's 7,000 new infections a year. So out of 50,000 in all of the United States, there's 7,000 in our state. And 75.7% of those are men who have sex with men. Medically, we call that men who have sex with men because not every man that has sex with men wants to be associated as being gay. So they're men who have sex with men. And there's different communities where being gay or being LGBTQ is handled differently, and that's all part of this conversation, and that's why it's so utterly important that we talk about this very, very openly and that we keep an open mind. Who knows how HIV is transmitted?
Bodily fluids.
That's great, there's many. Which one?
Blood. Blood.
Blood's one. What else?
Semen.
Why did that come so fast? Get it? When I turned around.
It came from a lesbian.
Okay, we gotta talk. What's the lady equivalent of semen? Vaginal fluids. And what does the female chest produce that the male chest doesn't produce?
Breast milk.
You're good. Okay. And then basically, any bodily fluid that contains this could carry HIV as well, okay? What are the acts in which you may get exposed?
Bottoming.
Bottoming? Not the other way around? So, unprotected sex, and we'll talk about what unprotected means, I think. Okay, what else?
Needles.
What?
Needles.
Needles, yes. What else? What does the child do on the mommy? Yes, that one. Occupational exposure. So there's people that can be exposed during occupational, things. So those are sort of the main areas where this comes from, right?
Right.
Has anybody ever been associated with any of this? Yeah? Okay, cool. So it's good to know about them. Now, what I'm going to do really quickly is I'm going to quickly talk about how HIV works in the body, or how it actually reproduces. Okay. This is a CD4 T helper cell. Actually, if I add this in it, which is its little core, that contains its DNA. So the DNA is what our body needs to reproduce, right? So that's our sort of genetic code. So everybody in this room has a different DNA. However, what HIV is it's a virus. So the virus needs to reproduce in the body, and the retrovirus does this a little different than anybody else. So let's assume there's this little virus cell that comes into the body, and usually when an infection happens, that's not just one cell, it's not 50 cells. The lowest possible infection that has ever occurred was with 362 cells in a milliliter of blood. So just to give you an idea of how this works. So basically, this little cell comes in, and it has little receptors on it. It looks a little bit like a sun right now, don't laugh. And then the CD4 helper cell has little harbors, basically, or receptors. And what HIV does, it goes to those receptors and then docks on the CD4 T helper cell, thinks, haha, got you. I'm going to take care of you and kick you out of the body. But what the virus does is it actually goes inside of the cell in order to reproduce. So there's 4 big steps that basically happen. So there is something called fusion. Then in here, when the cell has sort of been in there and has sort of opened up, there's something called reverse transcriptase. And then there's something called integrase, which happens in there, which needs to happen in order for so basically the DNA opens up, the RNA of which is a single strand of DNA, from the virus cell, goes to the DNA, copies itself, makes copies of the virus, and then basically puts it out, and there's another enzyme that's called protease. And then the virus cell goes out, there's a lot more, and then the virus sort of replicates in the CD4 T helper cell dies. When we talk about prevention, so there's a certain risk associated. Risk always sounds bad immediately. So the reality of life is everything has a sort of risk. If I walk across the street and I don't check for the bus might hit me, so that's a risk. How high or low that risk is sort of determines on what I need to do in order to reduce that risk so I don't get hit by the bus, which we learned. So we look left and we look right. In other countries we look right and then we look left, and then we don't get hit by the bus. And then, ta-da, we all survive. So what we're trying to do is, obviously there's many different ways. I can also just not cross the street. That's another prevention option. So when it comes to STIs and HIV, there's numerous ways of avoiding potential infections. What's the easiest one that Reagan mentioned in 1981? Is that really the easiest one? No, it's not. So abstinence is one of them. Then there is something called zero sorting, which means I only have sex or intimate relationships with someone that has the same HIV status as I do. That works for some people it doesn't work. Regular testing every 1 to 3 months. I sometimes get tested every month because sometimes I'm more sexually active and sometimes less. But regular testing is a prevention option. Knowing your status and knowing your health and knowing what's happening is a prevention in itself. Condoms is one. That's the one that we've been using for 35 years, and I think it's a really good thing. Then there is PrEP, which is post-exposure prophylaxis. So imagine, okay, there is a certain timeline. Over here, I am long before sex. At least rectally 7 days before, vaginally 20 days before, I take PrEP. Now it comes to sex, condomless or with condom, and I am protected. Does that make sense? So that's PrEP, that's over here. Even before that comes testing because I know my status. Then there is one called condoms. That's right before. I slip that thing on, we go, we're done, great. Prevention method achieved. Now something happens with that condom, it's post-sex, post-exposure prophylaxis now sets in, and I can potentially take that, and I can prevent. Now if everything fails, and somehow the virus should infect me, it's not a death sentence anymore nowadays, because we can treat people very, very successfully, and that's called TASP, treatment as prevention. Because this cycle repeats itself. I don't just have sex once. So what we do is, if somebody has HIV, we treat them so damn well that they literally cannot transmit the virus, and that's called TASP. And that's about 96 to 99.86% sure. And then we repeat this from the beginning, however much often we want to do. Okay, so those are the main prevention options, and that's a little bit of the timeline. And I think that the one that we all want to learn about today, which is PrEP.
Thank you all for being here tonight. And I really want to thank Robert for inviting me. I got this email kind of out of the blue a couple of months ago saying, hey, you don't know me, want to come to Bakersfield? How can you say no to that? So here we are. I'm an HIV and infectious disease specialist. I grew up in New York, and I did my training in Boston. And like a lot of people who are from the Northeast, we have a very Northeast-centric view of the world. Like, you know, there's sort of the Northeast, and then there's like Hawaii. So if you had ever told me I was going to move to LA, I would have said you're nuts. But in 2006, I moved to LA, and with an interest in prevention, although I had come to it with a background from HIV care and treatment, it was really fascinating to me that you use some of these same medications that we use to treat people who are HIV infected, but in people who are negative. And as Eric was talking about, there's this strategy called PEP, this post-exposure prophylaxis stuff, right, that many of you probably know about. If you've worked in a healthcare facility, you know that if you get a needle stick, or a splash of blood, and you're not sure if the person has HIV or not, or maybe you know they do, if you take HIV treatment medications as quickly as possible after that needle stick or splash, you can reduce the chance of you getting HIV by about 80%. You have to take that cocktail of medications for 28 days for it to work. And if you believe me, and I hope you will, that the most important parameter in PEP working is the time that you were exposed to the time you got the medication into the body, so how quickly you got it in. And we actually think that it works best if it's taken within the first 8 hours. of that exposure, most guidelines say you should consider getting it out to 72 hours after the exposure, but as quickly as possible. If you believe me that that's the most important parameter, how could we possibly make that time from the exposure to the dose as short as possible? Well, the answer, if you sort of think about that riddle for a second, is, well, if the medication's in your system already when the exposure happens, then the time from the exposure to the dose is 0, right? Because it's already on board. So it was from that notion and the observation that PEP works best the sooner it's given after the exposure that PrEP, pre-exposure prophylaxis, was born. Now, a lot of people think that's crazy talk. You're going to give HIV uninfected people medications that have side effects that cost a lot and that you have to take regularly for a long period of time to people who are negative. Well, on what planet does that make sense? And at first blush, that might seem sort of crazy. But let's think about it for a second. If you were to travel to Africa and you were afraid of getting malaria, before you went, you would start taking pills to prevent malaria. You would take it every day while you were there, and then for some period of time after you left that area, not because you were planning to get malaria, but in case you got exposed to it to prevent you from getting it, right? Same idea. Why do women take a daily birth control pill if they don't want to get pregnant? Not necessarily because they're planning to have sex on that given day, but if they do, and they don't want to get pregnant, they want to be protected. How is this different? Well, we can talk about that, but conceptually it's the same thing. Now let's think about one category that we didn't talk about of ways you can get HIV is a woman who's positive who gets pregnant, right? Mother-to-child transmission. The rate of an HIV positive mother infecting her baby, this is everybody in this country, about 25%. Worldwide it's about 40%. But let's say for the sake of argument 25%. But if the HIV-infected woman who's pregnant is on treatment and you give an intravenous regimen during labor and delivery and you treat the baby for 6 weeks after they're born, you can reduce that to less than 1% of those babies who are infected. So if you believe me that that's true, and I promise it is, and that works, isn't giving that medicine for 6 weeks to the baby really post-exposure prophylaxis? Because the baby was exposed, they're not infected, they're negative. We do this. We do this all the time. So why is it so crazy to think about this pre-exposure prophylaxis? I don't think it is. But in 2005, 6, when some of these studies that I'm going to tell you about were starting, a lot of people said, this is crazy talk, it'll never work. And if it does work, it's going to breed resistant virus. And even if it doesn't breed resistant virus, it's going to make people go out and have all kinds of unprotected sex with everybody in the world. And it's going to be a complete nightmare because then STDs and HIV are going to be transmitted everywhere. This is what was said. Hold those thoughts. We're going to come back to each one of those points. Fast forward, 2010. It was around Thanksgiving of 2010. These results were published in the New England Journal of Medicine. And this kind of turned the world on its ear. Many of you have heard about this study. It's called the IPREC study. And the IPREC study, that actually is the name, it's the abbreviation of the study in Spanish. It's like Iniciativa Pre-Exposure Prophylaxis, something like that. But so that it was overwhelmingly in South America, but there were sites here in the United States as well. They took 2,500 men who have sex with other men and transgender women who were HIV negative, and they randomized them to either get this medicine, Truvada, and many of you know Truvada as part of the cocktail that we use to treat people who are HIV infected already. It's not enough to treat someone who's HIV positive by itself, right? We need at least one additional drug to add to Truvada for it to be a complete cocktail to treat HIV. And it works against this enzyme that Eric talked about, reverse transcriptase. So the way I like to think about HIV is if viruses aren't alive, so you can't kill them, they're little robots. And that's even more scary to me. Clowns and robots scare me. I know, that's therapy for me. But anyway, so the virus is a robot, and it injects its genetic material, its RNA, as Eric said, into the cell. And then this reverse transcriptase is the first enzyme that has to work on that RNA. And what Truvada does, it's a monkey wrench that gets thrown into the gears of the robot and stops those gears from going and stops the virus from replicating itself. That's the mechanism by which Truvada works. So fantastic. So they either got Truvada or they got a placebo pill that looked, smelled, and tasted just like Truvada. You couldn't tell if you were getting the Truvada or this fake sugar pill that didn't have any real active medication in it. And people were told to take it every day, and they were tested for HIV once a month, Eric's favorite time frame. And they were tested for STDs every 3 to 6 months, and more often if they had any symptoms. And they all got condoms and counseling about how to use condoms and recommendations that they continue to use condoms all the time, because number one, 50% chance you were getting a sugar pill that wasn't going to do anything. And number two, nobody's proven that this works. Right? So even if it might work, we don't know yet. So you have to protect yourself like crazy. So keep using condoms all the time. That's what everybody was counseled in this study. At the end of 1 year, the people who got the real Truvada as opposed to the sugar pill were 44% less likely to end up acquiring HIV. Now, I don't know if to you that seems like a high number or a low number, a good number or a bad number. I'll tell you, I was disappointed. When I heard that number, I thought, you're kidding me. You're going to want me to take a pill every day that has costs associated with it, that needs lab tests, that has side effects, that only works 44%? Forget it. This is not a conversation I'm interested in. But it turns out that people like to say, well, what are the comparisons, right? Well, what are some other reference points for HIV prevention for some other methods that Eric was talking about, right? So condoms for men who have sex with other men are somewhere in the 70 to 90% efficacy range. Now, again, a lot of people like to toss around the number 90 to 95%. A study by Dawn Smith that was presented at the big HIV research conference last year kind of turned that on its ear a little bit and said maybe condoms aren't quite as effective as we thought they were, and came up with this number of 70%. But it's still, those are pretty good numbers, right? And 44% compared with condoms, 70 to 90%. This, again, is that a conversation? But those are apples and oranges. Because these numbers, the 70 to 90%, are when condoms are used all the time, every time, exactly as they're supposed to be. These are people who reported always using condoms and were able to explain that they knew how to do it and endorsed doing it all the time. Okay, this 44% number is not that. That is not the protection that you get from taking the Truvada pill every day as prescribed. That is the average protection that was seen over all 2,500 people who were in this study. And I will tell you that less than 1/2 of the pills prescribed to people in the study were ingested by anybody. Now, what this means to me is something that you all know already. If you don't take a medication, it doesn't work. That's not a surprise, right? You don't take your blood pressure medicine, it's not going to control your blood pressure. You don't take birth control, likely you're going to get pregnant. You don't take this, you can't work. Plain and simple. So, what did they do? This is like, there's this guy at University of California, San Francisco, named Al Leue. He works for the Department of Public Health there. He's super smart. And he did this really interesting study. He took 21 HIV uninfected people. He split them into 3 groups, 7 in each group. First group, he admitted them to the hospital for a while, and he gave them Truvada 7 days a week. He watched them take it, directly observed therapy. And he measured the drug levels in the blood, knowing that they took it 7 days a week. So he knew the drug levels. Second group of people, he admitted them to the hospital and watched them take Truvada 4 of the 7 days a week. Again, measured the drug levels. Third group, same thing, except he gave them Truvada only 2 of the days of the week. Again, measured the drug levels. Okay? So he knew what drug levels you would expect to get with those different dosing patterns. Fine, so what? He went back to the IPREX data set and looked at the people who had each of those drug level ranges and tried to figure out what this protection number was for each of those drug levels. And it turns out that from that he was able to model, this is a mathematical model, from the data from the IPREX study, that if you took it 7 days a week and got drug levels that you should get from 7 days a week, you would be 99% protected. What? 4 days a week, 96% protected. 2 days a week, 76% protected. Now we have a conversation. This is not a clinical trial result. This is an estimate of the potential protection you could get if you could actually get someone to take it 7 days a week. Now what's clear from this study, if you imagine these numbers as contributing to that average, how often were the people in that study on average taking that drug? Not so often. But if you could get someone to take the drug 7 days a week, that's pretty impressive. Okay? So I think that's some of the most interesting data that's been presented. So one of the most important questions that people get is, if you believe me that that's true, that that's the potential, well, how much is enough? How many doses can you miss and still be protected? How forgiving is this dosing? And it's very important to know that all the information we have about this is only in MSM, men who have sex with other men, and transgender women. We do not know the answer to this question for heterosexual women, and it's not clear that we know the answer for heterosexual men either. We'll come back to that. They took all the people who were in this study once they had the result, as well as 2 other randomized studies that were like it, one of which involved youth, 18 to 24. And they rolled them over into this study called IPREX OLE. And OLE stands for Open Label Extension, because they said, okay, whatever you were on before, whether you were on the sugar pill or the real pill, now we're going to give you the real Truvada pill everybody knows, and we want you to take it, okay? Do you want that? And the first thing they noticed was 76% of the people who were offered it actually said, yes, we want it. So I don't know if that's a good number or a bad number, but it's 3/4, I suppose it's better than 50%. But these are people who came into this study wanting to take a pill for HIV prevention. Now that you know that it works, only 3/4 of the people wanted to really take it. I don't know what that says our ability to have done good education with the trial participants and communicate the results of the trial in a way that people understood the potential of this. Or maybe it just says, maybe people don't want this. And I think that's a lot of work to be done to figure out how people who are most at risk for getting HIV learn about this, know about it, and figure out if they're going to use it. But we'll come back to that too. So in this open label extension trial, they did some even fancier work. This Leue stuff was just like the tip of the iceberg. They got crazy here. On all the patients, they took a piece of filter paper, and when they drew blood on people, they took 20 microliters, which is like a pin drop worth of blood, and they put it on the center of that filter paper. It's called a dried blood spot, or DBS. And you're like, well, what are they going to do with that? You remember in like kindergarten, those like hole punches that you would use to make a single hole punch to like put something in a 3-ring binder? So they took that piece of filter paper and they hole punched out the blood spot, and they ran it through a machine that analyzed the amount of Truvada drug in the red blood cells. Now, the reason that's important is red blood cells live for about 90 days. So they could tell you, on average, how many doses a week of the Truvada people took in the last 90 days. So it's not like a drug level that you might take right when you go to the doctor's office that only tells you maybe how someone did in the last 2 or 3 days. This tells you, it's sort of like, for those of you who are medically inclined, there's this thing for diabetes called a hemoglobin A1C. It measures how high your sugars are over time. This is a hemoglobin A1C, but for Truvada adherence. Crazy, right? This is pioneered by this guy at University of Colorado named Peter Anderson. He's kind of a genius. So he did this, and he found out, and this is a result that gets sort of screamed from the rooftops when this study was published in July of this year, is anybody who took 4 or more doses a week on average did not get infected at all. Personally, I think that's a little bit of a dangerous message. I don't think we know that, because that's an average number. Let me give you a couple scenarios. Let's say I was taking my Truvada every day without fail for a month, and during that time I was having a lot of sex. And then I stopped taking it for the next 3 or 4 weeks. My DBS blood levels might look like, on average, over the last 3 months, I was taking 4 to 7 doses a week, and I was protected, but maybe it's because I wasn't having sex when I wasn't taking it. What we don't know is how many missed doses in a row, or how intermittent dosing with relation to when you have the exposure protects you. We don't know that yet. So I get kind of hives when I hear people saying, as long as you get 4 doses a week in, you're fine. We don't know that. What this result says to me is there's some forgiveness. You can miss a dose here or there and probably be okay. But it would be irresponsible of us as providers and educators to tell people that we can recommend taking it less frequently than every day at this point. People are studying other regimens and other ways to take it that's not every day, but we don't know yet. And the last thing you want is for someone to think that they're protected and end up getting infected anyway. Okay? That's what we know about men who have sex with other men and transgender women, about the efficacy. But at the very beginning, I raised a number of concerns, didn't I? I said, number one, what's it going to do to people's sexual risk? Right? This has there's sort of a medical behavioral science term for this. It's called risk compensation. Basically, it means, are people going to toss their condoms out the window because of this? And remember, this protects you against HIV. It doesn't protect you against gonorrhea, chlamydia, syphilis, warts, herpes, right? So all of those things increase your chance of getting HIV infected. They increase your susceptibility, right? So if people get STIs and they're not treated, you can be at more risk. So people have done these mathematical models that if people even increase their number of partners or their unprotected partners by a little bit individually, across the world we could actually see an increase in the HIV epidemic, because PrEP isn't perfect, right? Nothing's perfect. So this is an important question that we need to answer. Next question, resistance, right? Okay, obviously people are getting infected with HIV even though they're taking PrEP. And Truvada is a key component of the medicines that we use, the cocktails that we use to treat people who are HIV positive. So if somebody breaks through, I'm putting that in quotation marks, Truvada-based PrEP, are they harder to treat? Do you then have to use different medicines that are less well tolerated? And then a lot of people who like doomsday scenarios will tell you it's going to start a whole new epidemic where everybody's getting infected with Truvada-resistant virus. And that's scary, so we shouldn't do this. Another argument. We'll come back to that too. Disparities. Right? So everyone knows that there are communities where HIV is incredibly stigmatized already. And a lot of those individuals have less access to HIV care and healthcare in general. If this costs a lot, how are we going to make sure it gets to everyone equitably so we don't exacerbate already existing disparities in the haves versus the have-nots? Is this going to be something that only people who are educated, wealthy, privileged, already in care are going to be able to access? Or is this going to make the entire HIV epidemic worse by singling out people who can't access this, doesn't matter how powerful it is? If anyone has an answer to that one, I'd love to hear it. And then another important one is who is going to prescribe this, right? Who knows the most about HIV medicine prescribing? It's the HIV doctors or the HIV providers, right? But those people usually see people who are already HIV positive. So who sees the at-risk negative people? Primary care doctors. You all know that primary care providers are very busy, have very short appointments, have a lot of priorities, a lot of times aren't comfortable prescribing these medications, dealing with the side effects, and with HIV testing. And then what do you do if somebody seroconverts, and how do you manage that? People like to call that the purview paradox. What that means to me is everybody putting their finger on the side of their nose and saying, not me. All the HIV providers are saying, I'm too busy, clinics are too full, I may know how to do it, but I don't have the capacity to take on a whole bunch of negative people to do this with. Primary care providers are saying, not me, I don't know enough about this, I'm not comfortable. And my favorite story was the time I got referred someone from one of the primary care doctors in the UCLA medical system. Why? To take a sexual history. No lie. In order to talk about this, you need to talk about sex. You need to understand risk. You need to be able to have a conversation about how people are or are not putting themselves at risk. A lot of primary care doctors, or primary care providers, I need to stop saying doctors, don't want to or aren't comfortable doing that. That's a problem. So who and where this should be done is a big problem. If you're negative, do you want to, particularly if you come from a community where HIV is still extremely stigmatized, be seen walking into a place that's identified where people get HIV care? A lot of people don't. So where do you put this? Now, I don't presume to have answers to all these questions, but I can tell you a little bit about what we do know. About sexual risk. People call this the belt and suspenders conversation, right? If you're wearing a belt to keep your pants up, are you also going to wear suspenders? No, of course not. That's silly. Unless you're making a fashion statement, right? But the point is, are people going to all of a sudden throw condoms away and if they're using PrEP? So all of the randomized studies, like the PrEP study that I told you about, there are actually 4 other studies in different populations that I didn't tell you the details of. We can talk about them if you're interested. I didn't want to bore you to death. That showed that numbers of partners and condomless sex actually went down over the course of the trial. It didn't go up. There were not more partners, and there was not more condomless sex. So I would argue to you that, well, that's nice. That doesn't tell me anything, because if I enrolled you in this study and said, hey, want to take a pill? It might work, might not. Or you might be getting a sugar pill, 50-50 shot, so you better keep using condoms. Are you going to go out and throw your condoms away? No. Probably not, right? But if I now tell you, hey, this works maybe as well as 99% if you take it every day, and you know you're getting it, is there a possibility that you're actually going to toss the condoms away? Yes. And they didn't see that in this PrEP study. Again, condom use actually went up, and numbers of partners was the same or slightly decreased. I will tell you that other STDs stayed the same, which makes you wonder. It didn't go up, that's good, but it also didn't go down. So I'm not sure that I believe that people really were safer, but at least it's a little reassuring that maybe people didn't put themselves in harm's way more. My personal theory is that there's a whole group of people out there in the world who are just fine with condoms. Maybe we don't love them, but you use them because you understand that they're protective. And then there are people who just aren't, for whatever reason. They can't, they don't, they won't. Those are the people in whom the new infections are occurring, right? So this protection is really most beneficial to those people. Are there some people who kind of hate condoms but feel like they need to do the right thing, and so they kind of try and they don't really succeed? Yeah, probably. And might those people be pushed one way or the other? Maybe. But I really think that people in general fall into those two major groups, people who do and people who don't. That's my personal theory. That's not necessarily borne out by any data or any studies. And you can tell me that you disagree, please do. So this remains something to be determined in real clinical practice. We don't know the answer yet. Resistance. We've not seen it except in one clinical scenario. You all know that every HIV test has a window period, right? You can be infected, but the test hasn't yet turned positive. And depending on what kind of test it is, that window period is a different amount of time, right? The most commonly done HIV test is somewhere on the order of 3 to 4 weeks, depending on which test we're talking about. That's just your general HIV test. There are some newer tests called 4th generation antibody antigen tests that are somewhere on the 10 to 14 day window. They're better. And there's the viral load test, which is the most sensitive test, which is 5 to 7 days after an exposure. But the most common one that's done somewhere on the 3 to 4 week range. So in the PrEP study, the only people who got resistance to Truvada were people who had a regular HIV test that was negative, and it was negative when they started the medication. And they showed up positive at the 4-week time point after they had started the medication. And they went back and they did the viral load test, that ultra-sensitive test on those earlier blood samples that they had stored away. And it turned out they were super positive. So those people were really in that window period when they started the Truvada-based PrEP. Those people got resistance to Truvada. Everybody else who actually got HIV while they were on the study, they didn't have resistance. Without boring you to tears, I'll tell you my theory as to why that is. I think the rates of resistance look something like this. Oh, that's kind of phallic, isn't it? That was not my intent. So this is adherence. When people don't take the medication at all, and they get exposed to HIV, you get infected. But there's no medicine around to get resistant to, so you don't get resistance. There's some level above which, if you're taking the medicine often enough, you don't get HIV infected, so you don't get resistance. There's some area in the middle, we don't know how wide it is, where that point is, where you're taking it not enough to protect yourself, but enough to still get resistance. And I would bet you that it's really people who aren't taking it, get infected, and then start taking it after they got infected, but they didn't know that they were infected. I bet you. I cannot prove that, but that's what I suspect we'll end up seeing. In that study, they tested people every month. Now, there are some people, some patients, who will be okay getting tested every month. The CDC guidance and the WHO guidance on how to use PrEP says test every 3 months. So that's a much longer time period during which if someone wasn't taking it, they could get infected and then say, oh yeah, I should be taking my PrEP, and start it again and take it for a while before they come to a test that would identify them as positive. So I worry, now that we're using this not in a clinical study context, that we may see more resistance. But we don't know the answer to that question yet. That make sense? Sort of. I haven't put you to sleep just yet. Now let me try a little harder. Okay. So, disparities. I got nothing to say to this except a challenge. To our public health colleagues. I think the question, if we're going to use PrEP as part of our prevention menu, is to figure out how to make sure we make it accessible to anybody who's at risk, regardless of their ability to pay, regardless of their ability to get on ACA-funded insurance programs. And it's going to take a real collective, collaborative effort to figure out how to do that, how to leverage insurance support when it's available, but how to be a payer of last resort for people who don't have access to that. I think, personally, that that's the only way we're going to prevent this from exacerbating existing disparities. The WHO, I have no idea about this one. I'm an HIV provider, and I see PrEP patients because nobody else will. And I think it's important, so I do it. I've had a lot of providers call me and say, is this a crazy thing to do? My patient asked me about this. I've had patients call me in tears because they went to a provider who slut-shamed them for seeking PrEP. Said, you must be promiscuous if you want to do this. And my response is, I think it's an incredibly brave thing to do, to take charge of your own sexual health and decide that you want to protect yourself. And a lot of people don't agree with that. And we can have a political discussion about it, we can have a moral discussion about it, but I think the bottom line is what Eric and Rob introduced this talk with is there are 50,000 new infections in the United States every year. That has not changed in the last 10 or 15 years. Everything that we are currently doing is not impacting those incidence numbers. We need something else. Should this be in the water? No. Is this for everyone? No. Should this be an option for people who want it? I think so.
I don't quite understand. Is there any difference in Truvada by age?
What?
Well, I don't understand it, I guess.
Well,
oh, is the age of a person?
Yeah, okay. I assume, not the age of the pill. You know, the 2004 Truvada was excellent. There was a rosé that year. It's the reason it's a really good question is, you know, that 44% number in the PrEP study, right? People didn't take the drug well. Well, who didn't take the drug well? Or are there people who took it better than other people? And answer, yes. Guys who were older took it better. And by better, I mean more regularly. Younger guys did not take it as well. And, you know, now that we have that information, you can begin to ask some questions about, well, why? They did not ask that question in the PrEP study, but it's an observation. But that's also true in HIV treatment studies. Younger guys tend to not be as adherent to their HIV treatment meds compared with older folks. And, you know, is that a feeling of invincibility? Is that other priorities? Is that also maybe there's drugs and alcohol in the mix more when you're younger? We don't know. We don't know the answer. But there was an observation that it's not that it works less well necessarily for younger people versus people who are older. Just they took it less well, so it worked less well. If everybody took it the same number of days of the week, there's no indication that it would work better or worse for anybody.
As parents of a gay son, what questions should our son be asking of his healthcare provider? What should he be looking for in a healthcare provider?
Well, the number one thing that's important with any provider, my opinion, is a collaborative relationship, right? You don't want someone who's going to be paternalistic and be like, you need to do X, because it should be a conversation, it should be a partnership, and you need a level of comfortability where you can talk about these issues that are really sensitive. And by really sensitive issues, I mean sex, I mean condom use, I mean drug use, I mean alcohol use. I mean, these things that are hard to talk about, that our society has made difficult to talk about, that we have shame around talking about. But this is about being sex positive, that people are entitled to and deserve a healthy sex life. And they can be safe in a number of ways, and how we as a healthcare community can help people be as safe as they can be and have a healthy sex life.
Can a person still drink alcohol on Truvada?
Great question. Yes, short answer. There is no direct interaction with alcohol or recreational drugs. And so if someone is drinking or using drugs, it's all the more reason that they should take the Truvada regularly, because maybe they're more likely to make some decisions if they're in a situation where they're going to be having sex, where they're less likely to protect themselves, or maybe more likely to have maybe some additional partners, or maybe have more prolonged sex. And so that's an even more reason to take it. It is worth knowing that, you know, all these medications are processed, metabolized by your liver. So if you piss off your liver from other things, it's not going to go well for that medication either, but that's not a reason to not take it.
My partner is HIV positive for many years. I am HIV negative. I have insurance and am interested in taking PrEP. How do I get my primary care doctor to prescribe PrEP? And more importantly, to get my insurance to pay for it?
The bottom line is, I can't make a doctor want to do something. And if the doctor isn't knowledgeable about it, or tells you something that doesn't sound right, you need to find a different doctor. And how to find that doctor, that's hard. Right? We're struggling with this in LA County. Is there a lot of doctors who aren't comfortable with it, and there's no directory of people who are comfortable with it. We're working on that. We're working on it for LA County, we're working on it for the state. So we're trying to accumulate a list. The problem is a lot of providers are in the closet about providing PrEP because they're afraid that they're going to get inundated, which I think is a crock and is kind of shameful. But we're working on it. So you can feel free to call me, you can get in touch with Eric, and we will work to find someone who is PrEP positive. I'm sure Rob will work also. You know, the folks at the LGBT Center here, they know how to get in touch with us. We will work to find somebody locally who is PrEP friendly.
Insurance is a good question. I think, so just a little background story. I come from East Germany, so I'm German, I'm European, and I've been used to having health insurance my entire life. So I never knew a time when I wouldn't have health insurance. So I think with the ACA introduction in the United States, with the Affordable Care Act and all of this insurance coming through, everybody's a little bit confused as to what this all means, and in some states people oppose it, which makes no sense, personal opinion. With insurance, Medi-Cal, for example, covers PrEP completely. There's no copay. It basically means you go to your doctor. There's Project Inform is an organization up in San Francisco, halfway up that way, and they have a pamphlet online that is called "How to Talk to Your Doctor About PrEP." So if you go to Google or Bing or all of these magical places, you enter "How to Talk to Your Doctor About PrEP," you will most likely end up on this page. If not, please send me an email and I'll be happy to share my email address and everything else. Pretty easy, it's literally this@gmail.com. I'm blonde, so sometimes I cheat and I'm like, what is it? Just without the dots, that's confusing. So that's Medi-Cal. Then there is private insurances. Aetna, Kaiser, Blue Shield, Blue Cross, too many blues in there.
Blue Shield?
Yeah. Oh, really? Okay. So they cover it too, but it depends on which insurance plan you're on. So on the bronze level plans, generally there is a very high copay and there's a very high deductible, and these need to be met before this medication is paid for. Just to note, the medication itself is worth about $1,300 a month. So as most insurance plans cover it completely, that's a huge, you know, that's a great cover, right? Now, some insurances have a copay of up to $300 or even more dollars. Now, for that point, there's Gilead, the producer of this medication, actually has an assistance program for that. So what happens is they basically pay for your copay up to $300 a month. Okay? So anything that comes out of your own pocket, they will help cover. If you are uninsured or underinsured, up to 500% above federal poverty line, which comes to about $58.5 thousand a year, $58,500 a year, sorry. Gilead will actually provide the medication completely for free as long as there is a prescription by the doctor. The other thing that we spoke about, and I just want to reiterate this, PrEP is not just a pill, it's a method and it's a regimen. So what happens is before you get onto it, you get an HIV RNA test. Your doctor will look at your kidney and your liver and your blood values and everything else, make sure that everything is in order for you to go on it, and he doesn't see any indication that this is wrong. And that's something that is part of the conversation you can have with your doctor. Once you've had that, what happens is for the first 3 months, you'll probably go back to your doctor every month, and he will again check all of those values. Then he will do it, and then he will go to HIV and STI tests quarterly, one of the good ones, and then every 6 months they will check your kidney and liver. Okay, so that's part of this regimen part, and I think that covers access.
Does PrEP help if you're already positive? And that's
No.
okay.
Right, that's really important, right? PrEP is only if you're HIV negative, right? If you're positive, you need a cocktail that may or may not include Truvada, but will have a combination of medications that will treat your virus. Truvada by itself is not enough if you are HIV positive. PrEP is for HIV negative people to try and keep them HIV uninfected.
What are the side effects?
So, 3 big categories of side effects. First, a startup syndrome. What does that mean? It means the first 2 to 4 weeks when you start taking the medicine, most people get some sort of gastrointestinal issues. Either they get an upset stomach, or they get the runs, or they get constipated. Some people get a little headachy. In the PrEP study, there was a bunch of guys who lost their appetite and lost weight when they started. So I was like, is that me? That's the startup syndrome. The way you handle it is, if you get the runs, you take some Imodium. If you get constipated, you take some fiber. If you get a stomach upset, you make sure you're taking it with food, or you can take some antacids. Overwhelmingly, that goes away after about 2 to 4 weeks, and there are very few people who had to stop because of it. But I find that if you tell people that that's likely to happen, they deal with it a lot more easily than if you don't say anything. They're like, they'll be fine, and then they start feeling, nauseated, and they're like, what's happening? So that's the startup syndrome, and that's not usually a big deal. The next 2 things are big deals. Okay, the first thing is kidney irritation. Okay, we know from people who are HIV positive who take Truvada as part of their cocktail. Remember, Truvada by itself not enough, complete cocktail. That Truvada, the components of Truvada, irritate your kidneys. In people who are positive, HIV also irritates your kidneys, and some people actually got irreversible kidney failure from Truvada-based treatment. In the PrEP studies, that has not happened. There has been some kidney irritation that was seen, but it all went away when people stopped the medication. And most people, once the kidney function was returned to normal, were actually able to restart the medication, and it didn't irritate their kidneys again. That being said, watching the kidney function every time someone comes in to get checked for their HIV is a critical piece in using this safely. And you put the kidney function blood test number into a formula that takes into account people's age, their race, their weight, and their gender, and it calculates your kidney function for you. And there's a certain number. If you fall below that, means your kidneys are irritated beyond a certain point, they need to stop the medication. And that's really important. Okay? So anybody with pre-existing kidney problems, it may not be a good option for you. And that's someone who might have diabetes, who might have high blood pressure, might have a family history of kidney problems. You need to get your kidney function checked before you start the medication. All that make sense? Now, if that isn't fun enough, just wait for this one. BMD. What? BMD is bone mineral density. Again, we know from people who are HIV positive who take Truvada-based cocktails that the Truvada makes you get brittle bones. In people who are HIV positive, you lose about 3 to 4% of your total bone mineral density in the first year, and then it kind of evens out. You don't continue to lose it at that rate. But in people who are HIV positive who take this as part of their cocktail, there is an increased risk of fractures of the bones. So that's not great. In people who are negative who take it for PrEP, in the PrEP study, there was a loss of 1% bone mineral density over the 1 year that people were on treatment. We don't know yet if that stabilizes or continues to decline. But that 1% was with people basically taking less than half the doses. So is that actually a lowball estimate of how much bone mineral density you might lose? I kind of think so. So I worry about this, okay? So what could you do to prevent this? We don't know for sure, but in people who are positive who take this, if you take a calcium and a vitamin D supplement, you can mitigate, reduce the amount of bone mineral density you lose by half if you take that calcium and vitamin D. So anybody that I put on PrEP, I recommend they take a calcium and vitamin D supplement. It hasn't been proven to reduce the bone mineral density loss in PrEP, but I bet you it works. We're studying it now, so we'll know soon. But I do recommend that to everyone.
How do they measure the bone mass density?
So in these studies, they actually did these studies called DEXAs, which is a bone mineral density test. It's like a super CAT scan, and they did it at the beginning and at the end. We don't do that regularly in clinical practice. It'd be great if we could, but they're super expensive tests, and most insurances won't pay for them unless somebody is in a...
So it's not in the blood panel that they
No.
Okay.
No.
One of the things that I'm a Truvada whore. I actually take PrEP, and I've been taking it past the point where starter syndrome would set in. I didn't have anything, just FYI. But what my doctor did, Dr. Mills in Los Angeles, before he put me on it, they actually measured my my vitamin D levels and my magnesium and calcium levels and stuff like that in order to see whether I already have less than I usually should have in my age group. And they prescribed me vitamin D in addition, and I just take calcium as well, just to be.
And I think that's a smart thing to do. I recommend it to everybody.
So that's easier than a BMD test.
BMD. Those are the three big categories of side effects. So as you can see, it's not a free ride. Most people tolerate it just fine. These are rare complications, but they're important complications to know about. Now, one important thing to remember, when we first were learning about AZT treatment in the late 80s, right, and AZT came out, we didn't stop when we had AZT, right? We kept developing new drugs that were better, that were safer, that were more effective, right? So this is the first set of medicines that works for PrEP. It's not going to be the last. So while these have some pretty serious side effects, even though it seems like it's exciting and works really well, this isn't going to be the last thing you're going to hear about PrEP. There are going to be other agents, there are going to be other ways to take it. The field is going to continue to evolve. What you're hearing is a snapshot. I promise you everything I'm telling you today is true today. But science moves fast, and tomorrow it might not be true. So I ask you to sort of forgive me a little bit if next week something comes out that makes something that I've told you today turns out that, that it wasn't up to speed, because the field is moving extremely fast.
Guy is HIV is non-detectable as he's taking his cocktail. Can an effective sexual relationship occur? Can he give me HIV by oral sex? Are you willing to provide a prescription for me for PrEP? How can I get in contact with you?
Let me answer the last question first, because that's the easiest. It would be completely irresponsible of any provider to give a prescription for PrEP without a full medical evaluation. So find a provider who can fully evaluate you, whoever asked that question, and they can determine if PrEP's right for you. That's the easy part. So the other question is the million-dollar question. I know Eric and probably others are going to want to weigh in here. But the question that's sort of on the table is a complicated one, right? You have a serodiscordant couple, which means you have two people. Let's not even call them a couple. You have two people, one's positive, one's not. Okay? They're having sex. And for a minute, let's pretend that it doesn't matter if it's men or women or two men. Okay? Let's just pretend for a second that this is, that's going to come out wrong. All comers. I know, poor choice. Just snorted. Okay.
Mr. Leather snorted.
Now you're blushing. Okay,
Just draw your recall.
for every sex act, there is a, we science people, we like to get very nerdy and wonky about this, right? We're science nerds. We like to say,
So there's a per coital act risk of transmission for every coital act.
right? And it's different for receptive anal intercourse. This is so clinical. It's like evolving something that's fun and pleasurable.
Taking it up the butt.
Yeah. Insertive anal intercourse.
Putting it in the butt.
Receptive vaginal intercourse.
I don't know that.
Insertive vaginal intercourse. And then there's oral intercourse, right? Every one of those, there's a risk, right? And we're assuming no condoms here, right? And we can talk about what the risks are. But what we know is if the positive person is on treatment and they're undetectable. Does everybody know what undetectable means? If you do, you're way ahead of me, because undetectable is a mishmash of everything, right? Undetectable refers to...
There, go ahead.
It refers to the viral load, right? The viral load is how much virus is running around in every milliliter of blood, right? And over the years, the tests have gotten better and better and better. And so a bunch of years ago, undetectable meant less than 400 copies per milliliter of blood, copies of the virus. Think of Xerox copies, right? Then the test got better and it became 75. So if you were less than 75, you were undetectable. Then it became 50. So if you're less than 50, you're undetectable. Now a lot of the commercial tests that you can get in a lab go down to 20. So less than 20 is undetectable. So it's a moving target. And if you go to a research lab, they can go down to something that they love to call, I love this, they call it SCA. You know what SCA is? Don't be quiet. SCA is the single copy assay. So it goes down to 1. So it goes down to 1 copy per ml. So the tests are going to keep getting better. So undetectable basically means that your treatment is making the amount of virus in your blood so low that it's below the limits of whatever the test can find. But that's a moving target. So if the positive person is on treatment and undetectable by whatever test you're doing in the moment, the chance of them infecting their partner is whatever it was based on what the sex act was before, reduced by 96%. So another way to say that is somebody who is on treatment is 96% or more less infectious to somebody else than if they themselves were not on treatment. Does that make sense? So what number you started from, and most of the per coital act transmission risks are on the order of between 1 in 1,000 and 1 in 100, depending on what kind of sex we're talking about. This being descending order of risk. So bottoming being the highest risk and oral intercourse being the lowest risk. Okay? Whatever the number is for that sex act that you're doing, you're dropping that risk by 96% or more. Okay? There's one study that everybody loves to cite. It's an observational study, which means it's just looking at people. And it's looking at MSM couples where the positive person is on treatment and undetectable, and presumably they're not having sex with anybody else other than each other. I call that monogamish. And over more than 2 years of follow-up, there have not been any negative partners who got infected. So people like to say, that means it can't happen. I don't know that it means it can't happen. There are all sorts of ifs, ands, or buts, no pun intended, that could contribute to someone still transmitting to their partner even though they're on treatment and undetectable. If either person has a sexually transmitted infection, that increases the risk. Why? Because if you're positive and you're undetectable and you have an STD, it revs up the amount of virus that's in the genital secretions. If you're negative and you have an STD, it makes your cells more susceptible to the virus, and it also breaks down the lining that is protective, that prevents the virus from getting in. So that's a double whammy. Okay? Now suppose the positive partner is on treatment and undetectable, but then for whatever reason they stop taking their medicines. or that virus became resistant since the last time they had their blood work checked, then they're not really undetectable. And here's my personal favorite one. Just because you're undetectable in your blood doesn't mean you're undetectable in your genital tract. 20 to 25% of men will have intermittent little amounts of virus detectable in their seminal fluid and semen, even though they're undetectable in the blood. Can that virus go on to cause a new infection? Nobody knows the answer to that question. But if you do these super sensitive lab tests, you can find it. That makes me a little nervous. So is it impossible for somebody who's positive and on treatment and undetectable to infect their partner? Of course not. It's absolutely possible. Is it likely? Probably not. Is that a license to go out and have unprotected sex? That's like a biblical debate, right? The Swiss government has said pretty clearly, if you're on treatment and undetectable for 6 months, you don't need to use condoms anymore. They have said that. They have gotten bitch slapped by the public health community because of all these other assumptions that go into that lack of transmissibility. And there's, again, been some mathematical modeling done that shows if everybody in the world who was positive and on treatment and undetectable went out and threw the condoms out the window entirely, the rates of new infections across the world would go up by 25%. What's the right thing to counsel somebody about that you're having a conversation with? I don't know. I think it's really unlikely to infect somebody if you're really on treatment and undetectable, but there's no guarantees. And if it really is a monogamous pairing and everybody knows what the situation is and everybody's with their treatment program and no one has an STD, yeah, I think it's vanishingly unlikely you're going to infect someone. But that's a lot of ifs, isn't it? And are you going to take that chance? It's an individual decision.
So, I want to just remind everybody that unprotected and condomless are two different things. And I will reduce Dr. Landovitz's answer here a little bit, because being on PrEP is already protected sex, and that's how we look at this in many, many ways, because, and I may have just caused a deep breath over there, but the reason why we talk about as a protected sex, the question is there any form of safe sex? No. Is there, exactly, which is no sex. Is there safer sex? Yes. And I think what we need to understand is that this is about how far can I reduce the risk in order to allow myself to get into it, right? So the question is, when my parents were doing their thing on the beach and they didn't use a rubber, they knew the risk exists that my mother could get pregnant. And she did, because I'm here. But they decided that that risk was okay for them. So what we need to learn is not to judge somebody else's judgment, but to make our own decisions. And the question is, am I more afraid of getting gonorrhea, chlamydia, syphilis, or trichomoniasis that I can get through oral sex without a condom? And whoever uses condoms during oral sex, please raise your hand. I'd love to talk to you. I find that fascinating. I tried once. Or am I more afraid of getting a chronic infection that will stay for the rest of my life because there is no cure for it? And I think that that is two different coins to look at that spectrum. Without English, German, so complicated. Achtung. So, and as for the point of undetectable, the international standard of what means undetectable is if you are below 50 copies per milliliter. So undetectable in one way by the meaning of the word can mean that the test can't detect anything, but in general the most commonly used tests test down to 50 copies per milliliter, which then constitutes undetectability in general. So that's the medical term. And then when people, if anybody in this room knows about the treatment cascade that happens in the United States, I don't know if you want to talk about it, but we also look at how well are we doing in getting people on treatment, because what we just spoke about is if somebody is undetectable and really well on treatment, then the chance of the virus transmitting is so low, then what does that mean? And the thing is that in the United States, about 25 to 28% only are virally suppressed. So out of 1.2 million people, about a quarter has less than 200 copies per milliliter. That does not mean that they're undetectable. In the United Kingdom, it's 61% that are undetectable. Does that make sense? So the difference is tremendous. And the thing is that by us going out and talking about HIV negatively or making people feel uncomfortable about it, it veers people away from wanting to talk about their status. It veers them away from wanting to talk to their doctor and getting on treatment. So what we need to make sure is that we welcome this to the conversation too. I have never personally zero sorted. I've never decided I want to have sex with you because you're HIV positive. I rather go by, are you crazy? Or are you sane? That's a much better determinant for me. There's the treatment cascade. Yay, thank you. Okay, so that's 1.2 million people. This is so small. Dr. Landovitz, why didn't you draw that picture? So we think
Don't be a size queen.
So there's so we think 1.2 million people in the United States living with HIV. That's what we think it is, because there is an estimate of the number of people. I'm not going to go into how we calculate this because I'm a science nerd, but there's an estimate of the number of people that don't know that have HIV. So obviously we can't measure them because we don't know. So there is 84% about that are detected. So
Diagnosed.
What?
Diagnosed.
Or diagnosed. Then there is about what is this? In care? Oh, see, I skipped in care on mine. So it's somewhere between, I think it's 47. So there's about 47% of the people are actually in care. Then there is about 36 people that are on treatment. And then there's about 25% of the people, 28. In LA, San Francisco, those numbers are higher. But this is the national average. So if we think about this, this is how it goes. So the more we can make this rise, the better. But also what we have is that everybody sleeping with these 75% could potentially contract HIV at a larger risk than if they're undetectable. Does that make sense? Yes? So these people, it's good to have PrEP too, for those that sleep with them. Anyways, that's very confusing. I'm going to overread it.
No, I don't think it's confusing. One other thing I want to add to that is, remember, when you have a couple or somebody who comes to you talking about, should I take PrEP? And they're like, well, my partner's positive and they're on treatment, so everyone says that they can't transmit to me, so I really don't need PrEP, right? I always take it a little bit with a grain of salt that that's really the only sexual interaction that's happening, right? Because whether or not we like to talk about it, couples are not always monogamous. And sometimes not both partners know that they're not monogamous. Sometimes they do. And so there's always a role for the HIV uninfected person to take charge and control of keeping themselves HIV uninfected. And maybe they know that they're having other partners, and maybe it's actually those partners who are their biggest risk of infecting them, because maybe some of them are positive and don't know it. Maybe some of them are positive and not on treatment. Maybe some of them are lying to them. People do lie. It is a mean, nasty world sometimes. So if someone comes to me asking for PrEP, if it's safe to do so, it's a pretty rare day that I will not offer it to them with a conversation of the risks and benefits.
Why aren't the makers of Truvada advertising like crazy?
Yeah.
I asked them to come here and so they could talk about their assistance programs, and they never answered my email, so go ahead.
So I can't speak for them. I don't know why they do what they do, but they made a decision when the IPREX data came out and when the FDA approved Truvada in 2012 for prevention. It's been long-standingly approved for HIV treatment, that they were not going to market it for prevention because there was so much negative energy around PrEP, specifically from one agency based in Los Angeles, that's actually a worldwide agency that some of you may have heard about this, that went to bat quite fiercely to prevent the FDA from approving it, and has created an enormous amount of negative press around the use of Truvada for PrEP. So Gilead was, I think, extremely gun shy from that experience and made a decision they weren't going to market. They did fund educational initiatives with community-based organizations, but they made a decision as a company that they were not going to market. That's now all changed. They are now marketing like banshees. They are contracting with physicians and providers across the country to go out and do speaking tours to other providers using a promotional sort of mode, and they've decided now they are going to market it. I don't know what caused that change, but you're going to be seeing a lot more. Maybe Eric has some insights. I'm not sure which.
We've actually pressured Gilead for about 6 to 8 months now to come out and stand behind this product. And the elephant in the room is called AHF, and I'm just going to say it because I've been the one that's been speaking about it all the time. And it was attacked as a party drug, and people would get more risky, and people would do all of these crazy things that we just talked about that we just haven't seen happen. And in reality, being a community representative, I speak to a lot of my brothers and sisters out there, and I'm sort of like, well, you know, how do you feel? And some of them say, yeah, well, you know, I sometimes just don't use a condom anymore because I'm not, you know, I feel better protected through my pill. For others, it's the other way around, and for the next one, it's like, well, you know, I just didn't feel like doing the pill, and so I keep sticking to my condom. So the discussion is very diverse, and what we've done is we've pressured Gilead as well as the city of San Francisco. We've been talking to the state senate. We've been sending letters to Washington. We've been sending letters to the CDC. I sit on the HIV commission in Los Angeles County. I vice it, and I'm hopefully getting my commission seat soon. But so we're doing as much as we can, but there's a lot of processes in the background, and a lot of people are very, as you just said, gun shy, because a lot of organizations just don't have the funding to survive a lawsuit. And I think that the more data comes out, the more confident we get that this is true, and that we can actually really look at it, and we can take it, and we can say this works. And now it's really come to the point where this is being pushed more. And just to say this too, the copay that I just mentioned was actually just increased in October, which was also due to community efforts of people calling Gilead, sending emails, sending letters, sending petitions saying, we want more support, we need more of this. And the same is happening now in Canada, it's happening in the United Kingdom, Germany is discussing it, so there's many more countries, because right now the US is the only country that's the forerunner on HIV prevention like this. And all the other countries are a little bit behind. So it's happening on a scale. But considering 1981 to 1994, I think we're moving at a pretty damn good speed.
Denise Smith, this question is for you. Where in Bakersfield can I get tested?
The health department offers HIV testing Monday through Friday, pretty much pretty much coming in anywhere between 8 to 4:30, 8 to 5.
And it's free, right?
Yes. And then Clinica Sierra Vista also offers testing in a lot of their facilities. You can come in for STI testing and get an HIV test also.
Is Planned Parenthood one of those?
I'm sorry?
Planned Parenthood, are they informed about this? Planned Parenthood?
Planned Parenthood does some HIV testing as well.
Where do I get, even begin with the process of obtaining PrEP, currently uninsured? Covered California is the first place you should start. That's my opinion. Do you have anything different?
I think getting on insurance, if that's an option for you, is the best first line, because even if you get on the Gilead Assistance Program to get the medication without insurance, you need a way to be able to pay for the testing that goes with it. So getting some form insurance is really required at this point to do this. But we need better methods for people who can't get on insurance. But unless some of you know of ways to do that right now, I don't.
I can only speak for LA. I don't know about the organizations here in the city, and the Department of Health will probably be really, really good contact for this. But in LA, the LA LGBT Center, as well as APLA and about 6 other organizations, you can actually go to them. They have medical services like doctors, etc., that will do all of the blood work. They will do everything. They are authorized to also give the prescription. The way that they operate is that they come from public funding as well as donations. So they look at your annual income, and then it's sort of, the cost sharing is a little bit on a sliding scale. So there is a way, even if you're uninsured, but with the Affordable Care Act, it's really well done to look at insurance and see if there is an option to get insured.
And you can find out if you're eligible for Medi-Cal through Covered California.
Yes.
And Medi-Cal does cover it. So.
Yes.
And in Kern County, there's 2 different Medi-Cal providers: Kern Health Systems, which is Kern Family Health, and Health Net. Their formularies don't have it, but it's part of their carve-out, part of Medi-Cal's carve-out. So Medi-Cal will cover it. The providers don't. So, but it is covered.
And Robert, I'm on Blue Cross Blue Shield, and my doctor prescribed it, and they didn't ask any questions. I sent it to the pharmacy, and they just filled it. Done.
That's what we're hearing about many private insurances, so that's great.
No question of that.
That's the way it should be.
It's a $30 copay. I guess they would take care of that if I asked them.
Yeah.
I'm going to try.
They will. Whoever is insured with Aetna requires a pre-authorization, which most of the doctors know. So one of the other good ways is to actually call your insurance ahead and just say, hey, I want to get on this pill. Don't be confused. Many of the insurance agents have no clue what you're going to say. So you need to explain it a little bit, tell them that you want to get on this medication and how is this medication covered under your plan. And then they will tell you in which copay tier they are, what's the deductible application, blah, blah, blah. But for most of the HMOs, it's covered as a preventative. It's basically covered in general because it's covered as an HIV medication, but it's covered as a preventative medication.
What is the age of the older person who takes the medication more reliable? I think, what are the statistics of somebody who's...
Maybe 30s and 40s.
No, so in that study, they enrolled people age 18 and up, and I think, I'm not remembering off the top of my head, I could look in this for you. I think it was like 18 to 25, and then 25 to 35, and then 35 to 45, 45 to 55, and above 55. And each category, people did better as you got older. I may be getting the break points between the categories wrong, but it was a clear increase in how well people took the pills as they got older progressively.
If HIV is more detectable by testing semen, why is blood tested instead?
So it's not that it's more detectable. So just so you know, you can't go into your doctor's office and say, I want the semen tested. It's not commercially available, okay? It's actually a super hard test to do that people sit there, because there's all sorts of enzymes and stuff in semen that make the test very persnickety and difficult to do, so only research labs do it. So it's not that it's more detectable, it's just that if you are undetectable in blood, occasionally, if you test semen every day, about 20 to 25% of those days, you'll find low levels of virus. I can't tell you if it's virus that can go cause a new infection, or if it's non-functional virus, a dead robot. I can't tell you that. No one knows the answer. But you can find virus there, and that worries me.
Okay. And my second question was, you mentioned the vulnerability of, that a person is increased vulnerability if they have a viral infection or a flu. But, so that's my question.
No, STDs. No, STDs.
Right, okay,
not flu.
STDs. But what about a regular virus or bacterial infection?
Probably not. Probably not.
So just to say, gonorrhea, chlamydia, syphilis, trichomoniasis, and herpes. So 3 of those are bacterial and they're local, so they are either in your mouth, your butt, or your pee or vagina. Whereas 2 of the other ones are viral, which means that they're in your bloodstream, basically. And depending on how they are acting in your body, they can basically. I always talk about it in the sense of the immune system is sort of busy with them in certain locations, and then it makes it more permissible. They can, like gonorrhea, I don't know if whoever has had it. I have, so I'll just talk about it. There is a white liquid that comes out of your front parts, basically with gonorrhea. When you have it in your mouth, it's usually like, you have a cough that doesn't really go away in your butt. Most people can't feel it and they don't see it because nobody can see their butt. But basically what it means is that there is an actual infection that is causing an ooze to be produced, which obviously creates a little bit of a door. So I think that that's sort of how we can talk about that. There is a chance that that increases the risk of transmitting or receiving, basically.
You said you were going to ask him the question. I actually live in Austin, Texas, and my doctor is was a pathologist, and he said that he says that the only negative about the Truvada is the acid buildup that it goes to the kidneys or something. Oh yeah.
So it can cause kidney irritation, but it doesn't build up acid.
He says they're going to be taking that portion out of the pill the first quarter of next year, and that won't even be a factor anymore. You haven't heard that?
No, it's actually not true. They're working on a new formulation of so Truvada has two components. It's got tenofovir in it,
right,
and then it's got this thing called emtricitabine. Those are the two medicines that are in Truvada.
okay.
So it turns out the patent is running out on tenofovir in 2017. So if you're Gilead, what do you do if your cash cow drug is gonna come off patent and be generic?
Right.
Well, you make a better version of it, right? So that's what they did, and it's something called TAF, and it's sort of a souped up version of tenofovir, and it's a lower dose, and it spends less time in the blood. And so they're talking about that they're going to reformulate Truvada to be. That's the third time. It's staying down there. And emtricitabine might be part of a new Truvada called Tafvada or something. I don't know what they'll call it. Anyway, so the idea is it's less kidney irritating, but it's not been studied for prevention. It's only been studied for treatment, and it's unclear if it gets into the rectal tissues the same way old tenofovir does. So it's unclear if it would actually work for prevention. So I think we're a long ways away from knowing.
Making assumptions.
Yes. So it's a great question, and thanks for bringing it up. And I do think we are working towards safer medications for PrEP, but we're not there yet. And just to tease you a little bit, the next thing is going to be injectable PrEP. And it's going to be an every 3-month injection, kind of like Depo-Provera. And that's something that's going into phase 2 clinical trials right now, which means it's not a 2,500 person study to show that it works. It's about a 175 person study to show that it's safe. Because if you give somebody an injection and it lasts for 3 months, it better be safe because it lasts for a good long time. So it better not make your kidneys explode or your head fall off. Or
And a question I should have wrote down, I'm sorry, Robert, but I know that people that are on HIV are supposed to take their medication at the same time every day, blah, blah, blah. But what about this? Does it work the same way where like you're supposed to take it at the same time every day? And what if you don't? What if you're taking it every day at noon, but you forget you don't take it till 2? Are you screwed up? Is it over? Is it done?
There's lots of forgiveness with it once you have it in your system for about a week. So what I tell people is as long as it's the same calendar day as you would normally take it, I don't care when you take it. But once it becomes that next calendar day, forget that dose that you missed and don't double up. Just keep going with what you were doing. It's not so precise that it has to be at 12 o'clock every day.
So I was into it 3 weeks and one day I screwed up 2 hours.
I think you're fine. You're more than okay. I would not even call that screwing up.
What I've discovered is that you take it when you do something every day, like brush your teeth, and there's something that I do every day, around the same amount of time. I plug in my cell phone every night before I go to bed, and that's when I take my pills. I get it on my cell phone.
So basically, calendars, there's apps for it, there is, there's all sorts of things, but basically Google Calendar will text you, and you can even set that in order to validate that you've done the reminder, you have to text back. So you can actually go back and check on yourself. And like, have you ever left the house and you locked the door and you like went into the car, you drove around the block and you're like, shit, did I lock the door? You did that. It happens when you take medication too. So with brushing your teeth, it's really easy because you go like, oh yeah, no I didn't. But with taking a pill, it's a little harder to tell. So what you can do is you literally set it on Google Calendar and then you just get a text from your Google Calendar and you text back and you're like, yeah, I love you too. And
Kids these days.
And there's also
like the Muppet Show.
There's also pill apps out there.
Who am I?
You're the bad Muppet.
So let's end on this. Is it conceivable now that a mixed status couple can have conceive a baby with this?
Yes, and you know, yes.
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 Done. Yes.
It does become complicated if positive guy, negative woman, he's on treatment, undetectable, she goes on PrEP, they have sex the old-fashioned way, they conceive a baby, great, and then they decide, okay, now for the rest of the pregnancy, they're gonna only have protected sex. Then you stop the PrEP, easy, okay, because she got pregnant, she's protected, no more unprotected sex during the pregnancy, right? And the reason you really want to avoid, more than the obvious one, transmission during pregnancy is a woman acquiring HIV during pregnancy is the highest risk situation for infecting the baby. So we ought to do everything you can to prevent that. But what if they're going to continue to have unprotected sex even though she's pregnant, right? Just because someone's pregnant, you don't stop having sex. But what if they decide they're going to continue to have unprotected sex? Now there's a baby, and now the woman who's pregnant is also taking Truvada all during the pregnancy.
Quick answer for this. What does Truvada have any effects with any other medication like antidepressants?
So there are some interactions, but not with antidepressants. It's mostly things that also irritate the kidneys, because the Truvada can irritate the kidneys, so you don't want multiple medicines that are irritating the kidneys. But there are very few direct medication interactions with it. Okay.
Even if you're taking PrEP, are you supposed to continue to use a condom?
The CDC says so.
Here's what I say. This is an incredibly complicated question that I think the answer is really, the words are really important here. Condoms are the best protection against HIV and the other STIs, the sexually transmitted infections. PrEP is great for the times when someone can't, won't, or doesn't use a condom.
Consistently.
Or the times when they do.
Yeah.
I'm so sorry, I'm so curious.
That's right.
But earlier, one of you that mentioned superbug, basically. You know, the
resistance.
Yeah, the resistance. And I don't remember hearing the follow-up on that. How does that go?
So we've only seen it when people have been in that window period and started on PrEP. So the way you fix that is before you start someone on PrEP, you send that viral load test and make sure it's negative. That's what I do, that's what most providers do in clinical practice. It's not in the CDC guidelines. They say if someone doesn't have symptoms, you don't need to do that. I get hives, and that's the second time I've said that tonight, at the thought of potentially giving someone a resistant bug, so I do it.
What did you say?
But there's no evidence so far that, you know, people taking it and that the bug is going to get bigger.
No.
Like GMO.
No.
Now the 2,4-D.
No. For the baby question, by the way, Bay Area Perinatal AIDS Center in San Francisco is an incredibly good resource. Shannon Weber is one of their directors. Look them up if you have questions about HIV positive to HIV negative children, because they actually deal with this on a daily basis. And if you look up a BBC interview that I was on with Shannon Weber, she actually spoke with one of her clients or patients that was on PrEP and conceived a baby that was HIV negative with an HIV positive partner. So, woohoo, Ruben. Sorry.
And I just want to thank each and every one of you. Don't you think that tonight was very, very informative? Yes.